Catherine Gilliss here, welcoming you to our April fireside chat. This is number 3 in our series, our spring series. And we are very pleased today to welcome as our participants, Chancellor Sam Hawgood and Chief Nurse Informaticist in the health system, Kay Burke. Some of you, I'm sure, know these two leaders on our campus from in one capacity or another. But let me just remind you that Sam Hawgood has spent most of his career here at UCSF. He is originally from Brisbane, and he came to us as a fellow in pediatrics and has had a number of very important leadership roles on our campus, including the chair of pediatrics and the dean of the School of Medicine. And of course, since 2014, he's been serving as our chancellor. And we're very pleased to have you with us today, Sam. Kay has been at UC since about the same time that I have been back here, December of 17. I remember meeting her when she was new to informatics at UCSF. She came to us after a career on the East Coast at MUSC and also at the Children's Hospital of Philadelphia. Kay, you had a title there that I found very interesting: business architect and senior solutions consultant. And I'm going to say, I think we all need at least one of those. Kay is prepared from Boston College with a degree in nursing, and she holds an MBA as well. We welcome both of you. We want to get into our discussion about AI. I had invited the chancellor to join us and asked if there was something in particular that he would like to talk about. And I think because of the meetings he was just finishing, he said, well, let's talk about AI. So Chancellor Hawgood, we welcome you. And I would begin by asking you if you would tell us a little bit about how you see AI unfolding on our campus and in the system, and tell us about some of the exciting initiatives that you know are taking place today. Thank you.
Yeah, thanks very much, Catherine, and good afternoon, everyone. I recognize many of your faces. Thanks for joining us. I'll keep my introductory remarks quite brief because, first of all, as I told Catherine coming into this discussion, I'm a cheerleader here, not a content expert, and Kay and others know much more about the specifics here. But each year I take the week off between Christmas and New Year, and in addition to sort of trying to unwind a little bit, I dedicate some time to thinking about what's a big issue that UCSF should be thinking about in the upcoming calendar year. And this year, the whole issue of analytics, big data, how we use it across all of our missions was the thing that rose to the top of the list. And that was in December, early January. And little did I know that in March, this thing that now is front of mind for everyone called ChatGPT was going to be launched. And it clearly has solidified this as a great theme for UCSF for this calendar year, to think just about how we can make sure that we are very thoughtful, but not so thoughtful that we're behind the rest of the world in using some of these new tools. And I don't restrict the conversation to ChatGPT, and I don't really even restrict the conversation to AI. That means a lot of different things to a lot of different people. Even the word I is not well understood when it comes to human intelligence. So I'm taking a pretty broad approach to largely, big data analytics and how it can drive our missions forward. The way I thought we would go about it, and this was again before OpenAI and Microsoft announced their breakthroughs in natural language processing, was to pull together a series of half-day retreats across the campus to brainstorm a little bit for me to learn what's actually going on, because as is always the case, when I don't think we're doing very much in a particular area and I start asking questions, I find out we're doing way more than I initially thought. But to identify what we're doing, where are our gaps, and where some targeted investments would move us forward, and also to eventually create a roadmap for us on campus that I could then try to get some of the outside world interested in helping us resource it. We're incredibly fortunate, as is the case in many subject matter areas, to be in the center of this current universe. You know, the company OpenAI is within walking distance of the Mission Bay campus, and there's probably 50 startups in San Francisco right now working on this, including, you know, Stanford, Berkeley, the Greater Bay Area. So we're in a fabulous position to lead. So we had the first of these half-day retreats 2 weeks ago. The first one was focused on the healthcare delivery. So where does big data analytics fit into healthcare delivery? We're just beginning to organize a second, which will be focused on the use of these tools in the research environment. And we'll follow up with probably 2 more, one focused on education and one focused on back of the house administration, which may seem a little strange, but I think one of the early safe applications of some of these tools is in efficiencies in things like HR, procurement, predictive analytics in all sorts of areas. So that's the plan. You know, I'm not a content expert, and I think that where we are in the cycle is we're in a time of overhype and a time of underhype. The overhype obviously is, you know, people thinking this is going to solve every problem and not being careful enough about some of the challenges that are created with these tools. The underhype is to dismiss it as a hype and not move forward. And I think that's, for UCSF, probably a bigger risk than the overhype. The other comment I would make is I've had the privileged position of talking to some of the drivers in this space over the last couple of months. I mean, drivers outside of UCSF, who are the developers of some of these tools. And what is very clear is the speed of innovation is unbelievable and almost beyond imagination. So it's a space that I think we have to be very intentional about what we want to achieve, and then move in sort of three places. And I would, you know, borrowing a model that McKinsey Consulting uses quite a bit around innovation. There's phase 1 where the tools are good enough now, and we just need to identify the right use cases and deploy the tools. And that's one of the areas we need to work in. And then phase 2 is really looking 5 years out and saying, where is this technology likely to be? And where do we want to play in that phase 2? And I think we need to execute in both of those phases. And in many ways we are. What came out of the clinical retreat was, again, an amazing inventory of things that individual faculty are doing in their areas, whether it's in cardiology and using AI to do, you know, ECG reading, which I know the School of Nursing is a major player in, whether it's in imaging, which is a early application of AI in the reading of X-rays. And I'm proud of the fact that a couple of years ago, UCSF had the first FDA-approved AI algorithm for the detection of pneumothorax on chest X-rays. But obviously it goes way beyond that. So we're doing a lot in different areas, but what also became clear in that retreat is we don't have an institutional plan. We don't have a stake that we're all rowing in the same direction to try to achieve. So I think on the clinical side, that's the next step to really determine what we want to do. But I think it has huge potential to improve patient care and improve clinician work-life balance and patient satisfaction. To take just a relatively trivial example, what we found when we survey the physician side, and I suspect it's exactly the same for nurse clinicians, is that the major reason they tell us that they are feeling burnout, or whatever the term you prefer to use for that general fatigue, professional fatigue, is the inbox, which is in and of itself a creation of a digital tool, the electronic health record. But there's fundamentally only so many questions that can be asked by patients in the inbox, and there's only so many answers that can be given, and that seems like a low-hanging fruit for AI to relieve some of the pressure on the inbox. And that's just one example of what I would call a phase 1 project. We don't need a major technologic breakthrough to achieve that. We just need the determination and the prioritization to make it happen. And there's any number of those. So that's where I am. I'm acutely aware of the risks when we move these technologies into the clinical space. We clearly need to think about personal security, data security. We clearly need to think about inherent bias and issues of equality. We need to be focused on inclusiveness when we apply these tools, that we're not further creating inequities in access. We have to think about transparency, reliability, safety. There's all sorts of issues that when it gets to the implementation, but I don't think any of them are insurmountable. And I think the time is now to do that. I'll just wrap up by saying on the research side, I think there are equal opportunities, things like DeepMind's release of AlphaFold, which is an algorithm that with incredible accuracy predicts the structure of proteins when the structure is unknown. And there are tools around to do much deeper analytics in genomic databases. And I'm sure each of you have thoughts and applications that could be used in the public health arena and in clinical research as well. So I'll stop there. I'm excited. I hope over the next 2 to 3 months we can really put a institutional plan in place. I'm already in contact with supporters of UCSF who are deeply engaged in this space from a commercial perspective. And I think there'll be a great deal of interest to hopefully use UCSF as a beta site for the application of AI in healthcare. So with that, Catherine, I'll stop, but look forward to the conversation, and I'll try to contribute as a non-educated IT expert in the conversation that we're about to have.
Thanks, Sam. We consider you to be our expert from 50,000 feet. You know what's happening on the campus and throughout the system, and that's pretty valuable to our conversation. As you've said, Kay Burke is our subject matter expert, and we invited Kay to give us a little bit of background on what she sees as really the opportunity and the value of AI in the nursing frame. And so, Kay, I'm going to turn this over to you as an expert, and we'll have a little Q&A after that, and then we're going to open this up for conversation.
Great. Thanks, Catherine. Firstly, I'm thrilled to be here. I'm so excited. I was counting down the minutes until this fireside chat was taking place, because this topic is near and dear to my heart, and I share a lot of the sentiments that Sam expressed in regards to where we are today and where we could be, where we need to be. I was unfortunately unable to attend the clinical retreat last week. I think I went to the Health Information Management Systems Society conference, which is why I was unable to attend. I was traveling. Perhaps the day after, or maybe a couple of days after, I was at the keynote address. So the focus of this conference this year was AI. And I was at the keynote address with Peter Lee, who actually spoke to that sort of dichotomy, the hype dichotomy of overhype and underhype. And he was a very compelling speaker. And he was joined on his panel by some folks that lived more in the overhype realm, right? So those of us that see incredible opportunity to clinical outcomes, patient care, clinician efficiency, combating burnout. And then there were those that lived in the more underhyped kind of realm. Perhaps that's a little bit of awareness and understanding of the benefits and the opportunities, but there's a lot of risks, privacy concerns, ethical concerns, to Sam's point. And so how do we strike that balance, right? While we're doing this correctly, responsibly, and taking into consideration of the GPT-4s, the chat GPT, all of the other generative AI opportunities, while also being focused on our mission to deliver safe and high quality care. So I thought, Catherine, maybe I'll just do high level kind of, I'm sure everybody's aware of kind of what is AI, but to Sam's point, I don't think that there is a common definition of not just AI, but even intelligence. So I might start with the tops of the waves, and then I can delve into some of the stuff that we are starting to do, some stuff we have been doing for a while, but I'll call that AI light. And then some of the things that we're talking about within sort of health system governance. So I'll start by, so it really is, as Sam said, it's really just the study of machines that exhibit intelligence. And there's a number of different types of AI. There is natural language processing. So that's really looking at the computer's analysis of structured and unstructured documented data. So to look at trends with what's been documented. There's also sort of image analysis, same thing of analysis of image data. And then there's a lot of talk about machine learning, and that's probably the biggest area of focus, I would say, right now. And these are not just predictive algorithms, but they're predictive algorithms that continuously learn and change. And so it's a subset of AI that I think is probably where the biggest opportunity is when we talk about healthcare delivery, specifically around nursing practice and impact. So it's like capabilities with experiences that refine the probabilities of an outcome. So, and just one comment about the generative AI and chat GPT, which is sort of another subset, if you will. We are an Epic shop. So Epic is our electronic health record, as you all know. And, you know, they had no choice but to lean into this. And try to figure out what were some initial use cases that they could support. And so they do have two, and one is the in-basket, that is loud and clear across most institutions, certainly here at UCSF, where the cognitive burden and additional minutes and hours spent sifting through in-basket messages is really a problem. And so they're starting to talk about how does ChatGPT create draft responses to patients when communicating asynchronously. And so that's kind of where they're in the nascent stages of talking through. I believe that they're partnering with UCSD, I think, in the investigation and development of that. And then the second one is barely in the nascent stages. I think they're just talking about it, which is sourcing recommendations from what's called Slicer Dicer. It's Epic's self-service analytics platform. Because usually you have to customize your search and you have to select the data sets to answer a question or try to investigate a problem. So with GPT-4, they're talking about really typing what your question is, and the system would automatically kind of recommend the different metrics or data sets you look at. So they are dipping their toe in that realm, and they had no other choice, because I do think that there's going to be a lot of opportunity in that space. So from a nursing perspective, you know, there are so many opportunities for you know, design and healthcare delivery, and how do we introduce more AI so that we're supporting diverse patient populations, and some of the things that we've already been working on, which are sort of AI light, which are a lot of the risk models that we have in place, a lot of the ones that we're developing. We have dashboards and other tools that are in our production system today that say, all right, you know, this model indicates that your patient might be at risk for catheter-associated UTI, for example. There are these 4 data elements: bundle compliance gaps, indwelling catheter over a certain amount of hours. Okay, nurse, you should probably think differently about how you intervene on this patient. That is really more, you know, predictive analytics, sort of 101. We have that dashboard in production. We've been working on similar work with early warning deterioration. Okay, we know these 5 clinical data elements are true. Therefore, we think that this patient will actually deteriorate in 6, 12 hours, or whatever the case may be. So a lot of those cognitive computing models are also being either piloted, in other words, run in the background so that they're being validated, or in some cases, they're already being utilized in at UCSF Health. So there's just opportunities for, you know, can even predict patient experience outcomes. And so a lot of thoughtfulness around what problems that you want to solve. To Sam's point, you start with kind of like initial pretty rudimentary use cases, and then you think through like, what are some of the data sources that you can build or deploy. So you either develop them or you deploy them from that have been developed elsewhere, and then you're able to, you know, make a different clinical decision as a result. One thing that I think everybody is aware of, I'm particularly excited about it, is we just launched our Capacity Command Center. So it's called the Patient Capacity Management Center. Essentially, it's, for those that have not seen it and you're interested in touring it, it's at 1800 Owens on the 4th floor. But it's physically co-locating a number of clinical functions to look at data and actually make decisions to support more efficient patient flow throughput as a result of now what we have in real time. So real-time metrics that indicate you might want to enact a surge plan or do something differently based on your role, whether you're central patient placement, you're the patient flow physician that day, or the EVS transporter. So a lot of data through these dashboards that we now have available to support more effective capacity management. What folks might not know about PCMC is that in scope for that project are predictive models. And we actually have 3 live algorithms. While I say they're live, they're examples of models that, because we really want to be responsible with, you know, with how these models are being used, oftentimes we run them in the background and we validate with real data, real patient data, real ADT data, but we sort of make sure that we have that validation lens. So one of them is called the destination location for OR patients. And so that one is live for surgery admits. We also are looking at bed availability. So looking at retrospective data to indicate where we think a bed might become available next. So that really does help with decision support for patient movement and our access folks. And then there's about 12 additional algorithms that's part of PCMC that that not just clinical operations, but a number of interprofessional colleagues are working on with our data science team and our informaticists. Sort of discharge delays. So we know we have discharge milestones. What delays can we predict as a result of a patient's either clinical condition or assessments and vital signs? And then there's something called OR come and go. So we're working on a model that talks about how do we level load the ORs a little bit more effectively and efficiently. And so there are many more, and maybe in the Q&A, folks will have questions about some other examples. But we do have the nursing services strategic plan that I know a number of you have contributed to. And within a lot, so we have many different sub-strategies, countermeasures, milestones, and tactics. The opportunities within this broad AI realm are pretty significant when it comes to us as a Department of Nursing really being able to execute on this nursing services strategic plan. So it's a very exciting time. I have to kind of go on that sort of privacy risk concern realm because it's really, really important to go there, which is why governance is really important. So I'll talk about governance in a minute. So as nurses, as clinicians, we need to ensure that we have that persistent focus on tequity. If you haven't heard the term tequity, it's gaining a lot of traction in the informatics realm. And as AI becomes a greater enabler of care delivery, we need to recognize the ways that its misuse can actually exacerbate, structural racism that exists in healthcare, exacerbates bias that is introduced in how we take care of our patients. And so there's a lot of talk about black box AI, which black box means just what you can imagine. You're not really quite sure what information is being generated and leading to these the outputs of such an algorithm. And so without data scientists, programmers, clinicians, users knowing, what went into this algorithm that's now telling me or suggesting to me to do something different, that's definitely an area of fear and concern. So we talk about social determinants of health, right? We know that non-medical factors are really the greatest contributors of health and wellness. So socioeconomic status and health behaviors and physical environment. So when we're bringing some of those social drivers or social determinants into algorithms, particularly if we don't have explainable AI, but rather black box AI, we're really at risk of making critical errors and really contributing to, frankly, inequitable care delivery, perhaps even perpetuating poor outcomes for our patients. So I'll stop there, Catherine, unless you want me to get into some governance or wait until some folks ask some questions.
Thanks very much, Kay. I wonder, before we go too much farther, would you just give us a little bit of an update on the thinking about digital technologies as they might affect the delivery of care, either by nurses, and Sam, please join in on this, but nurses or physicians, or even expanding the team, because we'll have digital tools to use. What's happening at UC right now?
So I can start, and please, Sam, jump in. Quite a lot. There, as you know, our Vision 2025 strategic plan did have an entire goal or pillar around digital transformation as part of our innovation at scale. And so and certainly COVID did help to accelerate some of these strategies, quite honestly. When we talk about digital, oftentimes we're talking about how do we gather data more quickly, more efficiently, so that we can incorporate those data into care delivery decisions, how to keep patients out of the hospital, how to incorporate patients' families when we feel like they could be an effective partner in making care decisions or improving their own chronic conditions. So there's this Internet of Things, which really is, we have remote patient monitoring tools. We're equipping people with Bluetooth-enabled scales. We're a consumer-driven world. People are buying their own tools, Fitbit, Apple Health, and they want their data that they're collecting on their own to be incorporated into their EMR. And so I think we have a virtual care strategy. We have, some of it is a little bit in the discovery phase, if you will, and some of it, including our remote patient monitoring, which the Office of Population Health is really doing an incredible job leading a lot of the initiatives there, mostly related to primary care support. That's one strategy or kind of area of focus that there is an incredible group of thought leaders talking about and working on. One area that's a little bit less crystallized, and I think it has a lot to do with the state of California not giving us really the green light or any healthcare institution within our state, which is a true hospital at home. And so how do we enable digital tools so that we are caring for our patients, effectively with high quality, the utmost patient safety in their homes, so they do not have to be in an inpatient environment. Whether it's remote patient monitoring, ED to home programs, full-on hospital at home, digital is going to be the way in which we're going to achieve these capabilities. There really aren't, there's no way around it, and we're going to have to be thoughtful about how we integrate these data, maintaining privacy, security, patient preferences, when we're gleaning all these kind of Internet of Things data sources into the clinical decisions that we make.
Yeah, Catherine, I would just add, and I'm glad that Kay brought up the hospital at home concept. I think it's clearly going to be a big part of our future. There are places on the East Coast. I did my annual meet and greet in Washington, D.C. in November, where I went from Congress office to Congress office, Democrat to Republican. It was kind of eye-opening, the different responses you get. But anyway, and I was joined on several of those visits by the CEO and president of Mass General. We always try and link an East and West Coast approach. And Mass General is making a huge investment in hospital at home. They see it as a major strategic driver to free up beds for the tertiary, quaternary population. And I think it's a huge opportunity for us. As Kay said, it requires some policy relief at the state level. But this whole digital informatics world is going to be the key to the success of that. And I would say nurses, but a particular kind of nurse that would be something I think very interesting for the school to be thinking about proactively. Mm-hmm. Nurses who are really well trained in these kind of new tools, the informatics, because many of them are kind of black box, but we don't want, we want people who know the pluses and minuses, like we all need to know the pluses and minuses of a drug. Yeah. Or a particular intervention. We need to know the pluses and, what are the limits of these technologies. And so I think it's a whole workforce readaptation that cuts across all of the healthcare professions. But I think nursing is, or could really own this space in a really interesting way.
Well, this wouldn't be the time for my faculty colleagues to be excited about starting yet another new project, but I have been approached by a number of people just in the last 2 weeks about the question of informatics and whether we're anticipating an informatics specialty. And I'm not making an announcement today, but I'm interested to find out from the faculty whether and how such an option could be available. Certainly, the resources are there outside of the school and within the health, some within the school. Certainly, the health system and the projects that you're talking about are the laboratory for students that we would prepare. So there's plenty of work to do. I'm aware.
I would say insurance companies and their foundations,
yeah,
which have lots of money given the profits that they've made over the last few years, should be very interested in this space.
We'll make a visit, you and I, maybe.
Yeah.
Yeah.
I did put in the chat a link to a YouTube that Peter Lee just produced about a week ago. Okay. It's a pretty long read. It's about an hour, but Peter is the head of global research at Microsoft. Very interesting character. We've had lots of connections with him over the last decade. But ChatGPT is going to make him a media rock star. And so you can look at his YouTube early on.
Catherine, can I just make a quick point?
Yeah,
Because
sure.
I would be remiss if I didn't touch upon this, because Sam already did, and I didn't. I talked a little bit about capacity management and quality and safety, and risk for harm events, and a lot of other things that can be impacted, or certainly are impacted, by professional nurses. One thing though is, burnout is real. You look at pretty scary data when it comes to the future of the nursing workforce across the United States. And when we talk about digital, I know I'm a mid-career nurse, but believe it or not, my first job out of college for 3 years, there was no EMR. It was all paper charting. And I don't remember being frustrated by documenting. I mean, I guess it was a little bit ago, but it wasn't something that concerned me. I get tired at the end of the day because I now have a chart. It's just a thing. And we did a similar survey to what Sam was talking about through the class research, which has a group called the Arch Collaborative. And we surveyed 7,000 clinicians, mostly nurses, but we additionally surveyed, ancillary services, rehab, et cetera. And the cognitive burden that is added upon our clinicians in a single shift is contributing to this mass exit of this professional career. We're not going to take EMRs away though, right? We can design them a little bit more effectively. We work on that day in and day out, week in and week out. But the digital tools and alternative care models, it's not just digital, but it's also, all right, how do we actually support nurses who might not want to be at the bedside for every shift? They want to participate in virtual nursing. They want to be part of hospital at home programs. They want to support tasks that excite them and allow them to work at the top of their license as credentialed nurses, while also offloading tasks at the front line. So direct care clinicians don't have to do X, Y, and Z, because that work can be done virtually. So for example, ADT requirements, admission assessments that don't need a direct care clinician, discharge education. So the patients need an RN to do this, but not necessarily a direct care RN. So some of the things that we talk through about AI, digital, specific to patient care and clinicians facing patients and delivering care, we also are talking about satisfaction and retention of our actually clinical workforce, that we have to be thinking differently about how do we support them and how they, these alternative care models.
Well, I'm reminded from that comment, Kay, that you and I met with someone who is an entrepreneur. We met maybe 2 or 3 weeks ago now. And the thing that was so valuable in the product he was talking about that he's designed and a possible partnership with all of us was that was a digital device that actually collected information and delivered information to the nurse, as opposed to counting on the nurse to get the information organized and get it into whatever the repository is. And I think that, I don't know, maybe that moves toward phase 2, but we clearly have experienced quite a bit of burden from the current systems. I want to open it up. I want, some of you I haven't seen for a while. I'm delighted. We've got ethicists here. We've got scientists here. We have clinicians. We have people from the health system, as well as faculty and staff from the school. So happy to begin to take some questions in the chat. If you have some, Beth Phoenix.
Yeah, being that my area is mental health, and that that so much of the positive impact of psychiatric nursing is, really comes from relationship-based care. I haven't really heard much discussion of how implementation of some of these AI tools may impact the, the nurse patient relationship?
I can make a comment, Beth. I think it's an excellent question and comment. There is a fellow at UCSF, and I now see that Jen Lyos from my team is on, and I know she met him as well. He talks about humanistic charting, right? So it's not just a 44-year-old Caucasian woman with a history of IBD and these vital signs currently in the ED, but it's Kay Burke. She's a mother. She has an adopted child, and she doesn't have any family in the Bay Area. That's me as a human, right? That's not necessarily me as a collection of data points that tells a clinician what to do clinically. This hasn't taken off, but think about humanistic charting in the spirit of ChatGPT, right? So you're not necessarily having GPT or AI combing through clinical data for an algorithm specific to a predictive model, for example, but rather gathering information that is more humanistic, that supports that nurse-patient relationship in a way that is respectful, dignified, and, enables patients to want to become healthier because they feel that they are treated as a person. So I don't know where that's going, Beth, but I do know humanistic charting is a thing, but it's kind of starting to bubble up, and I wonder if there's opportunity there.
Interesting.
I would add just two comments. I think the person you're referring to, Kay, is a fourth-year medical student called.
Oh, you're right. Yes, Sam.
Chris Montgomery.
Yeah.
He is an unbelievable mover and shaker. I think he's the only student that puts himself on my calendar about once a quarter just to update me with what he's doing. And I helped arrange a period of time where he went to Columbia Presbyterian. But yes, he's a strong advocate for that. And I think we are beginning to explore how to create modules in Apex for that. The other comment I would make that's specific to mental health, and this is very much a toe in the water, but I'm particularly interested in it. One of our foundation board members, a wonderful guy called Ken Howe, who is a senior partner at Silver Lake, got very interested in the intersection of technology and mental health. And so he is funding out of our citywide project that I'm sure you're aware of. It's a city-funded clinic in the Tenderloin that provides care for some of the most difficult patients, frequently homeless with severe mental health issues. But he's funded a program where a group of patients themselves helped design an app that is on a cell phone, and then we pay for the cell phone and pay for the maintenance of the app and give these patients a cell phone. And there are a lot of naysayers that say, well, that's just going to throw the cell phone away. But in fact, the retention is very high, and it allows sort of almost real-time and continuous connection between the clinic and the patient. And built into the app and the program is a sort of a reward system where if the patient meets certain milestones, sobriety for 3 days, they get a reward. It might be points, and there are other. And once you reach a certain point level, you get something meaningful in terms of a reward. So that's just one example. Jane, my wife, happens to be particularly interested in it, and we're following along closely. But one could imagine much more advanced utilization of some of these tools to remain connected to patients who might otherwise not feel a strong connection to a physical entity like a clinic.
Mika Estrada, you have a hand up.
I do. There's so many things to say. I feel like the chat GMP, one of the discussions that has come up around it is what is uniquely human? What does it mean to be human? And then I hear that again in terms of when you said the humanistic charting. And so I'm Miko Estrada. I'm the Associate Dean for Diversity, Inclusion, and Outreach. And I am really curious about, you mentioned, Sam, that, we had to be aware of safety issues, security issues, inclusion issues, equity issues, all of those kinds of things. I'm wondering how we are going to do that. And then the other question that came to mind was, we're talking about how to stay human in relation to our patients, but I'm also wondering, how do we stay human in relation to our education system? Because as all these technologies come in, and let's say we get rapid response emails to students, and we, it starts to have this kind of automaticness to it. Where is the care? Where is the kindness? Where is the generosity? Where is the loving and the heart and all of this? And if it's not woven into the algorithm, it won't be there. And then the last thing I'll say is also, it could center white culture even more so than it already is, and a white male culture, to be really specific. So what are we going to do to make sure that that's not happening in the process of it? I think it's going to happen very fast. I mean, I have friends who are working on this as well, and they say within 2 or 3 years we're not going to recognize anything. So just those are things that bubble up for me. Probably too much here.
Mika, you make incredibly powerful points, and I'll be very brief because I know we're close on time, but and I'll let Kay respond, but I couldn't agree more. And I think that the hope is that some of these tools will free up the time for clinicians to do that human contact. How you make sure the tools themselves aren't biased is a huge area of study that way cleverer people than me are engaged in. I think, ChatGPT basically uses the internet as its data set. So in so much as the internet is biased or excludes populations, there's a real risk that ChatGPT will as well. If you watch the Peter Lee video towards the end, he shows a very interesting example, because he gets into this question is, can AI be sentient? And what does it mean to be uniquely human versus machine? And if you run a ChatGPT 4 question, whatever it happens to be, particularly if it's got sort of human consciousness overtones in it, and the initial answer comes back, if you query it and challenge it in terms of bias or whatever, if that query is run through the same Chat GPT, it will tend to be defensive and say, no, I think I got it right. But if you run exactly the same query through a separate Chat GPT, it will say, you're probably right, and I should have included X, Y, and Z. So, they've released GPT-4. I was up in Seattle just 2 weeks ago, and they're working on GPT-6. So this is clearly moving very fast. And Kay, I don't know whether you have any insights, but.
Nothing really to add, since I know we only have 1 minute left, and I see that there's another question, but I completely agree with your comments, Sam.
Actually, we have several hands that have gone up, and I apologize to those of you who are left with your hand in the air. This has been I'm going to call time because we really are out of time, but we will save these comments and perhaps we can get back to them. This was recorded as well, and we'll make it available if you have other audiences that you'd like to share it with. Sam and Kay, thank you very much. I think you accomplished what I hoped, and that was that we would have a beginning introduction and overview and begin to get the juices flowing. There's so much that we can do to make a contribution in this space, one that will improve patient care and overall health. And I want to thank those of you who are with us, even emerita professors who came in for the session. Thanks so much to everybody for being with us today.
Thank you, Catherine, and thanks, everyone. It's a pleasure to be here.
Thank you.
Take care.
Bye-bye.
Bye-bye.